The myocardial cells receive impulses from two sources, from the intrinsic modified cells forming the conducting system of the heart, and from the autonomic cardiac plexus, which is composed of two types of fibers delivered by cardiac splanchnic nerves. These are the sympathetic and parasympathetic fibers. The conducting system consists of nodal tissue that initiates the heartbeat and coordinates the contractions of the four heart chambers, and highly specialized conducting fibers for conducting them rapidly to the different areas of the heart. The impulses are then propagated by the cardiac striated muscle cells, so that the chamber walls contract simultaneously. The conduction system of the heart consists of the sinoatrial and atrioventricular nodes, the atrioventricular bundles, and fibers of Purkinje. The sinoatrial node is located anterolaterally, just deep to the endocardium, at the junction of the superior vena cava and right atrium, near the superior end of the sulcus terminalis. This node is the pacemaker of the heart. The SA node initiates and regulates the impulses for the contraction of the heart, giving off an impulse approximately 70 times per minute. The contraction signal from the SA node spreads through the musculature of both atria. The SA node is stimulated by the sympathetic division of the autonomic nervous system to accelerate the heart rate, if necessary, and is inhibited by the parasympathetic division to return to or approach its basal rate. The atrioventricular node is a smaller collection of nodal tissue than the SA node. The AV node is located in the posterior-inferior region of the interatrial septum, near the opening of the coronary sinus. The signal generated by the SA node passes through the wall of the right atrium, propagated by the cardiac muscle, so-called myogenic conduction, which transmits the signal rapidly from the SA node to the AV node. The AV node then distributes the signal to the ventricles through the AV bundle. Sympathetic stimulation speeds up conduction, and the parasympathetic one slows it down. The AV bundle, the only bridge between the atrial and ventricular myocardium, passes from the AV node down through the fibrous skeleton of the heart and along the membranous part of the interventricular septum. The AV bundle divides into right and left bundles at the junction of the membranous and muscular parts of the interventricular septum. These branches proceed on each side of the muscular interventricular septum, deep to the endocardium, and then ramify into subendocardial branches, also known as Purkinje fibers. These fibers extend into the walls of the respective ventricles. The branches of the right bundle stimulate the muscle of the interventricular septum, the wall of the right ventricle, and the anterior papillary muscle through the septa marginal trabecula, also known as the moderator band. The left bundle divides near its origin into approximately 6 smaller tracts, which give rise to the subendocardial branches that stimulate the interventricular septum, the anterior and posterior papillary muscles, and the wall of the left ventricle. Impulse generation and conduction can be summarized as follows. The SA node initiates the impulse that is rapidly conducted to the cardiac muscle fibers in the atria, causing them to contract. Then the impulse spreads by myogenic conduction, which rapidly transmits the impulse from the SA node to the AV node. After that, the signal is distributed from the AV node through the AV bundle and its branches, the right and left bundles, which pass on each side of the interventricular septum to supply subendocardial branches to the papillary muscles and the walls of the ventricles. Impulses generated by the conducting system of the heart can easily be registered by means of ECG. As far as many cardiac diseases are complicated with conductive disorders, ECG is a very important diagnostic procedure. Electrodes placed on the arms, legs, and chest register electrical signals produced by the heart, generating a pattern of waves that show the polarization of heart muscle. Each wave or signal of the ECG corresponds to a certain event of the cardiac electrical circle. When the atria are full of blood, the SA node fires and electrical impulse spread throughout the atria, causing the depolarization. This is represented by P wave on ECG. Atrial contraction starts in 30 milliseconds after the P wave. The PQ segment is a time as signal travels from the SA node to AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave means that depolarization of the main mass of the ventricles is happening, and S wave is the last phase of ventricular depolarization at the base of the heart. ST segment represents the interval between ventricular depolarization and repolarization. This is when the ventricles contract and pump blood. T wave represents ventricular repolarization immediately before the ventricular relaxation, so-called ventricular diastole. The cycle repeats itself with each heartbeat. Obtained ECG pattern is then compared to the normal records and analyzed to determine the nature of the problem. And we are back to blood supply. As we discussed a bit earlier, the arterial supply to both the SA and AV nodes in 60 to 80% of right dominant cases derives from the right coronary arteries. But the AV bundle traverses the center of the interventricular septum, the anterior two-thirds of which is supplied by the septal branch of the anterior interventricular artery, which is the branch of the left coronary artery. Ischemia caused by coronary artery disease can cause damage of the conducting system of the heart, often resulting in disturbances of cardiac muscle contraction. A heart block may occur. In case of heart block, the ventricles will begin to contract independently and at their own rate, that is 25-30 times per minute, and you see it's much slower than the normal heart rate is. Well, the atria continue to contract at the normal rate if the SA node has been spared, but the impulse generated by the SA node no longer reaches the ventricles. Damage to one of the bundle branches results in a bundle branch block, in which excitation passes along the unaffected branch and causes a normally timed systole of that ventricle only. The impulse then spreads to the other ventricle via myogenic conduction, producing a late asynchronous contraction. The fibrillation is the most difficult type of asynchronous contraction, characterized by multiple rapid contractions or twitching of the muscular fibers. Ventricular fibrillation is the most disorganized of all these arrhythmias, and In its presence, no effective cardiac output occurs. The condition is fatal if allowed to persist. An electric shock may be given to the heart through the thoracic wall via large electrodes, puddles. The shock causes cessation of all cardiac movements, and a few seconds later the heart may begin to beat more normally. In some people with a heart block, an installation of artificial cardiac pacemaker may be necessary in order to generate the rhythmic impulses and stimulate the cardiac contraction. The pacemaker consists of a pulse generator, battery pack, and electrodes. The pulse generator is placed subcutaneously, usually below the clavicle, while the electrodes are inserted into the subclavian vein and administered to the right atrium. Some devices have one electrode, others have two or even three. If the patient has problems with just one SA or AV node, a one-chamber device with one electrode will be used to compensate the function of this node. If both nodes are damaged, the two-chamber device with two electrodes should be installed. And this is what you see on this X-ray picture. One electrode is inside of the right atrium, and the second one is advanced into the right ventricle via the tricuspid valve. The biventricular devices have third electrode, and to place the third lead to the left ventricle, the opening of the coronary sinus is used. Inside the heart chambers, the electrodes are placed in contact with the endocardium.